Hello, good evening, everyone. Thank you for joining us. My name is David. I work for Medtronic, and tonight I have the pleasure of hosting this webinar where you'll get to hear from Dr. Neal Patel. Dr. Patel is a urologist at Advanced Urology, and he's a Georgia native. He earned his medical degree from Chicago Medical School and completed his residency in urologic surgery at Rutgers Robert Wood Johnson Medical School in New Jersey. Dr. Patel is a strong patient advocate, and his satisfaction lies in providing his patients the opportunity to return to normalcy to their lives. Dr. Patel believes in educating his patients on the many aspects of urologic disorders and treats each patient with an individualized approach. He specializes in treating voiding dysfunction, both urinary and bowel. Tonight, Dr. Patel will be speaking on overactive bladder, urinary retention, and fecal incontinence or stool leakage, as well as advanced therapies that help treat each of those. Before I pass the mic to Dr. Patel, here are a few reminders. Everyone's phones were muted upon entry. If you have a question, please feel free to type it in the Q&A box at the lower portion of your screen. All names will remain anonymous. We will answer these questions following the presentation. Likewise, please answer the anonymous poll questions during the presentation and the anonymous survey at the end. And now, without further ado, allow me to welcome Dr. Patel.
Hi, good evening, everyone. Thanks for joining us tonight. I'm going to just share my screen here so that everyone can see. Let me just see here. Okay. Hey, David, do you mind just advancing the slides for me? My computer is not letting me share. Hey, David, do you mind just advancing the slides for me?
Oops, sorry. Yeah, there's the first page right there.
Okay.
You got
All right, there we go. Yeah.
There you go.
Perfect. Okay. So thank you, everyone, for joining. Thank you for the great introduction, David. I see a few of my patients on this call, so thank you so much for joining, and hopefully we can help educate you on all the options available to you for bladder and bowel control. So we're going to start off the call by discussing the nature of bladder and bowel control, sort of the care pathways that are in place. We'll go over the treatment options and discuss the Medtronic INTERSTIM system for neuromodulation, and then we'll end it with some questions and answers. So the biggest thing you need to understand is that you are not alone. There are about 1 in 6 women who undergo overactive bladder over the course of their life. We also know that 1 in 4 men also experience similar things related to an enlarged prostate. So it's a fairly common problem that we see. It generally starts with patients who can't make the road trips, or through movies, or through restaurants, or know where all the bathrooms are at the malls and sort of public areas. And the reason this is, and we'll get into a little bit, it's just, it unfortunately is part of aging, and it happens to some people sooner and other folks later. And there are various causes and reasons for this to happen. So let's talk about what's normal. So, and really what isn't. So again, the most important thing you have to know about this, it is not a normal part of aging. It's very common to go through the aisles in the store and see the diaper section and say, oh, this is just, marketed towards me because as I'm getting older, these things happen. But it's really your body talking to you. And it's not a good part of aging because there's a really important quality of life impact that you have from these types of conditions, especially when your urinary habits or bowel habits begin to govern how you behave as far as your social activity, as far as your ability to wear clothes out or not worry about having leakage episodes or abnormal smells. And so what is this exactly? We call this frequent accidents, that all of a sudden when you're getting home, you have to go right away. A lot of people in my patients report they're getting home and they're turning off the car and they've got to go. And as they get closer and closer to the door and then closer and closer to the toilet, sometimes the urge becomes so strong that they can't hold it or make it. And it's a very uncomfortable feeling. A lot of my patients will also say that this happens to them, first thing in the morning when they wake up, and sometimes they can't even make it to the toilet. And that's usually what prompts them to coming in to see me. Again, like we talked about, planning activities around the bathroom, knowing where all your favorite bathrooms are at the malls, or knowing that you only have a certain amount of time to leave the house and come back before having to use the restroom. A lot of what people do is they will start reducing the amount of fluids that they take in hopes of decreasing the amount of urine they produce. And while it seems like a pretty interesting way of approaching it, the problem is that if you do that, you become chronically dehydrated, and that has other long-term health effects. And lastly, but not least, the chronic use of pads and protective garments, it becomes a nuisance, but also becomes an expense that you have to deal with for a long period of time. So the really important thing is that when this is happening, it's your body telling you, hey, something's not right here. All right, next slide. So how does the control work? So essentially, the way this all works is that when you're born, there's a center deep down in your lower sort of spinal cord area that is sort of what we call the toddler brain for bowel and bladder. And that's why we wear diapers when we were children. And at some point in our lives, our parents decide that they need to potty train us so that we can be socially acceptable. And so you go through this wonderful behavioral therapy process that's called potty training. And what that does is it allows your brain to sort of take over control of the bladder and the bowel so that you can control when it's time to go and be able to suppress those urges to go until it's absolutely necessary. And so this works by a feedback mechanism that goes from the bladder to the brain, and then the brain governs the bladder. But it's really important to know that the urine is made in your kidneys, which filter all the toxins out of your blood. And the urine then puts it in the bladder and it stores it until it's time to go. For the bowel, it's a similar method, meaning that as the rectum gets full of stool, it stimulates the nerves to say, hey, I'm full, which again goes to the brain. The brain tells you to get to the bathroom so that you can go, but it also starts the process of evacuation. And so again, these are things that are brought under control when you're potty trained, but it can break down over the course of your lifetime and obviously cause a big quality of life and social impact. All right, next slide. So things that you eat and drink can cause it. Medications and supplements you may take could lead to incontinence. Obviously, the less that you're mobile, the less pelvic floor muscles you use. And this can also lead to laxity over time, and that can cause leakage. And then lastly, injuries to the pelvic floor, history of radiation, pregnancies, and childbirth can all form different types of leakage. So there's three types of bladder control problems. There's what we call stress incontinence, which is when you cough, sneeze, or laugh, you leak. And that can be due to surgeries, that could be due to pregnancies, or just pelvic floor weakness. There's another type called urinary retention, where your bladder's not able to empty well, meaning that some men have an enlarged prostate that causes their bladder to become more overactive, but also decreases their bladder's ability to empty, and they can develop both the inability to empty well as overactivity because the bladder is working overtime to try and get the urine out. It can also happen to women for various reasons, especially if the bladder wall gets weakened and doesn't squeeze well. And then you can also have the inability to urinate. Infections are also a leading cause of urinary retention in some folks as well. Last but not least is overactive bladder. So overactive bladder is basically the bladder itself is just working overdrive. And now it can be caused by certain things like an enlarged prostate, but it can also just happen naturally with age. And that has to do with the fact that the nerve signals that go from your brain to your bladder to tell your bladder to behave and stay calm in socially acceptable situations have been disrupted. And so the bladder starts behaving like it was when you were a baby and starts going back into overdrive and just squeezing and trying to get the urine out as frequently as possible. And that's what leads to sort of your quality of life impact. So what is stress incontinence? Stress incontinence is when you leak, when you cough, sneeze, or laugh. It can be leakage when you sit up, exercise, bend over, do any sort of abdominal exercise, play tennis, or anything that has any sort of physical activity with abdominal exertion. A lot of folks have leakage when they climb stairs or just stand up from a sitting position. And sometimes they feel like they're going all the time, even when they don't feel like they have to go. They could be just sitting there and urine leaks out. And any small little thing can trigger a leak. And so this is one type of incontinence. As far as urinary retention is concerned, that's when it's hard for you to tell if your bladder's full, you don't empty well, you have a weak stream, maybe due to a prostate problem or a weakened bladder. Some folks need to use catheters to empty their bladder, and it can be, very much a quality of life, negative quality of life impact when you're not able to urinate or feel like you have to go and you can't, or having to use catheters frequently, which can become very frustrating. So what's overactive bladder? Overactive bladder is basically the feeling that you have to go, and it's sort of an uncomfortable feeling. So the urgency that you feel to have to make it to the bathroom, obviously that you feel like you go frequently during the day. Normal is less than 8 times a day. So if you're going more than 8 times a day, you're in that overactive sort of area. It's also this feeling like your bladder is just never empty. And as this gets worse, it may lead to leakage as you're going to the bathroom. So leaking before you reach the bathroom when you're getting home from work, or if you have that strong urge to pee in the morning when you wake up and you can't make it to the bathroom in time. All those things can cause you to have leakage. Also, you feel like you have a frequent amounts of leak. So even after drinking small amounts of fluids, you feel like you're leaking quite a bit. If you hear running water or your feet get cold, it's a common one. People feel like they have to go to the bathroom more often and leak. And then obviously when you're having leakage with the urge to pee, and which leads you to use diapers, pads, or any sort of protective garments, that's sort of when you know you have overactive bladder. In a similar sense, fecal incontinence is basically the same sort of pathways that govern your urine. They also govern your bowel habits. That's why we know that there is a strong link between bladder and bowel. So recurrent, it's basically an issue where you cannot hold your stool in, you can't make it to the bathroom in a similar way, and you have accidents that can be quite a bit more frustrating than even if it's just urine alone. It can happen with the urge to defecate. But it can also happen when you don't have you don't feel like you need to go. The good news is we do have treatments that can get you back to living life. It doesn't have to be the way that you govern your sort of life to be, and there are definitely options. The most important thing is that you should not feel that these are anything that are normal parts of aging. And our goal is to bring back that quality of life and work as hard as we can to make sure that that happens. Okay. So basically we go through these steps. First, we got to diagnose, then we try first-line therapies, which are lifestyle and dietary changes. Then we look at oral medications that can help you. Oral medications are are medicines to calm down the bladder or help make the bladder go more if you have retention, or if it's a fecal problem, giving you medicines to help with that. But medicines all have their side effects, and they're never fixing the underlying cause of the problem. And so that's why advanced therapies come into place. So we sort of try to walk you down this pathway from doing first-line therapies first, because if we can fix it with just some changes to your lifestyle, changes to your diet, changes to how you take fluids, doing physical therapy, then that's fantastic. We've had you avoid taking lifelong medications or any other therapies. The truth of the matter is that generally most folks end up either on medications or needing advanced therapies, but our hope always is that we can fix you with first-line therapies, because that's what we would hope for ourselves as well. So when we talk about lifestyle and dietary changes, I mean, it's really important that if you're overweight, you got to lose weight, you've got to do exercise, more importantly, pelvic floor physical therapy to help with strengthen your pelvic floor muscles, to help with any type of leakage that you may have. But also we do know that helps reduce overactive bladder symptoms. Diet is really important because we do know there are foods and liquids that can irritate your bladder and make you go more frequently. So working on these sort of first line simple solutions is always the first step that we do when we look at treating overactive bladder. Now, every patient is different. And, if you're a patient of mine, I do my best to tailor these treatments to your sort of underlying reason for showing up. So again, sometimes if it's a patient with an enlarged prostate, it's probably not going to help to do physical therapy in this case. The next step is oral medications. And this is specifically talking about medications that we give for the overactivity. So the way they work is they work by calming down your bladder in different ways. They all have different side effects. As we know, medications usually have some sort of side effects. My goal for my patients is to not have you on medications if at all possible. Generally, we always have to try medications to see how well you tolerate them, how well you respond to them, and see if they're a good option for you long term. Generally, these medications can cause dry eyes, dry mouth, blurry vision, constipation, high blood pressure, and in rare cases, confusion, and has been linked to early dementia. And with these side effects, all the studies that we've looked at show that most people aren't really taking them within 6 months of starting it. So if you're one of my patients and you're on medicines and doing well and you're still taking them more than 6 months out, I applaud you, but just know that there are other options to get you off medications. So that's when we get to advanced therapy. So we've tried the lifestyle changes, we've tried the medications, maybe we didn't like how they made us feel, or they didn't work for us, or we had side effects or reasons that we couldn't take them. Then you may hear me talk about advanced therapies, which are essentially therapies that we do to fix the underlying problem. Now, if you remember, we discussed that the issue is between the brain and the bladder, or the brain and the bowel. And so we hope that physical therapy or biofeedback therapy was able to help reestablish that connection. And if it hasn't, then we have to go in there and try and reestablish that sort of communication pathway ourselves. And so we do this with the same system. The same system actually works for both, depending on your needs. I have many patients who have both bladder and bowel incontinence issues that have had great response to this therapy, but you may have one or the other. And so there are options for bladder, which includes nerve stimulation. There's multiple types, as well as injected medicines, which is usually in the form of Botox. I'm not a big fan of Botox early on, mainly because it requires you to undergo multiple procedures every 3 to 6 months for many, many years. And my goal is for you to not have to see me. And so we try the advanced therapies that help give you a long-term response. For bowel control, it is essentially either big surgery or a nerve stimulation system to tell your bowel to behave as well. So when we talk about injected medications, which is an option for bladder, it is basically like putting Botox as we do on the face. It's the same exact type of Botox, but we inject it into the muscle of the bladder and we tell it to calm down. If it works too well, then you have a problem where you can't pee. And if it works great, it usually wears off between three and 4 months, and usually requires us to go back in about every 4 months to give you an additional dosage. This is always done under anesthesia, so that's always a consideration. And again, like I said, I would usually, for my patients, I try and find an option that doesn't require them having to come back to the operating room multiple times. The effectiveness of Botox is similar to oral medications. Unfortunately, it is not able to be used to be treated for fecal incontinence. And again, like we said, if it works too well, it actually makes your bladder too weak, and then you may have to self-catheterize temporarily for a few months, 1 to 2 months, until it starts wearing off, where you're able to urinate again. Most of my patients that have tried it don't really like taking it beyond a few treatments. The studies show that 51% of patients generally stop after 2 treatments. With sacral neuromodulation, now this is a great piece of technology. It's what I do, and what I think really gives a great long-term outcome for the properly selected patient. And basically what it does is, wherever that the pathway between the brain and the bladder is broken, where the brain cannot communicate with the bladder, this system basically picks up and starts sending those signals appropriately so that the bladder can behave and act calm. The important thing to know about the system is it does not at all go into your spinal cord. It does not go near anything in the cord. It is near some of the nerves after they've exited the cord, specifically the nerve that helps with controlling your bladder and your bowel only. And what it does is it emits a signal that gets picked up by these nerves and then taken to the bladder so that it can behave. And so with gentle chronic stimulation, we have found, and the success rates are incredibly high, that it restores normal bladder and bowel function. And again, this does not treat stress incontinence. It can treat certain types of urinary retention, and it can also treat overactive bladder in the form of urgency, frequency, urge incontinence. Before we talk about even talking about this device, we usually do a test. And so the test basically allows us to see if this therapy would work well for you. And if the therapy works well, you try it out at home for 4 days. If it works really well for you, then you come back and we discuss how you reacted to the test trial. And most of my patients, when they come back, they say, this is fantastic. I love it. How can I make this long-term? And then we talk about implanting one of these devices that you see on your right underneath the skin. Now, for reference, the INTERSTIM device, INTERSTIM 2, is about the size of between a quarter and $1. It's very thin, it's very tiny. It goes underneath the skin in your lower back, just above the buttocks. No one knows that you have it, not even you, unless you go searching for it. And we decide to do this only after you have a successful trial, and the incision to put it in is very, very small. And we could always remove it if for some reason the inciting problem is resolved over time, or you don't like it. But generally, most of my patients do very well with it, and we never have to worry about that. And again, like we talked about, the first step that we do is we do a test trial. So the test trial is just basically a monitor that we put on your back, nothing invasive. There's a little wire that goes right underneath the skin that does the test trial, and you try it out at home for about 4 days. And if you feel like you have a greater than 50% improvement in your symptoms in any category, usually we look for any 24-hour period where we see that could be helping, then and you have a great response, and we talk about how we could do the more permanent version of this, which is underneath the skin, sort of out of the way, where you don't have to worry about it, don't have to feel it or see it. And our success rates for this is about 89% now. So with bowel control, it's about 89%, and with bladder control, it's 76%, which is a significant amount. When we talk in medical percentage terms, I mean, that's a very high percentage rate. I would want that on almost any one of my therapies. And that's why we love it so much, because as a physician, I want to be able to give my patients the best outcome that I possibly can and make sure that they're satisfied with their treatment goal. And, as we go down the treatment pathway for a reason. But if we end up here, I do know that there's a 76% chance that they will be better with this therapy, which gives me confidence as a provider to say that we have a good pathway here. Unfortunately, I have some patients that come and say, hey, I just want to jump to this. And as much as we would love to, I think it's really important that we try the right steps to be least invasive to most invasive. And I don't even consider this invasive. This is more of like a minor outpatient procedure, but still, you know, we want to get your life back in the right orders and steps. And again, I think as a physician, this is a great sort of chance of giving you a better life. So you may ask yourself, is this right for you? I think, you know, you have to look at your symptoms. You have to look at how they're governing your life. I think most of the times there's a lot of patients that walk in the door and they know that they need to get better and they need to be fixed. There's a lot of patients that don't realize what their life could be. I've had some patients who came in for other reasons and just asked them, like, tell me about your urinary symptoms. And it turns out that they've been leaking for years and been wearing pads and they didn't know any better. And so it's really important that you understand. And sometimes they'll go, even those patients who felt like they were okay, who ended up undergoing the trial, realize how much better their life was with the therapy. So, you know, you may have been treated by another urologist or by a primary care physician. You may have tried lifestyle changes and medications, but you haven't really heard or thought of the next step. And you know, I do encourage you to seek it out because a lot of patients have side effects to treatments, or they're just not taking the medicines that were prescribed and sort of dealing with it. And I guess my goal for you is to figure out a way that we can help you get that control back without having to take medicines and without having to worry about it on a daily basis. So obviously, I'm interested in hearing any questions the audience may have. You know, if you're interested in this therapy, please reach out and make an appointment. If you're one of my patients and you feel like you're ready for this next step and you've tried medicines and lifestyle changes, definitely make an appointment and we can talk about how we can do the test trial and see if this is the right option for you. And if you're just new to this and you're just trying to understand what's going on with your body, I'm happy to sit down with you and sort of go through everything on a more personalized level and tailor the treatment plan to you. Any questions? These are some frequently asked questions that I can go through really quickly. The data shows that this has been effective out to 5 years and longer. I've had many patients that have had systems in for 10, 15 years and doing great. It's important to know that this is not a cure-all. I'm not trying to sell you a cure to your symptoms. What I'm trying to let you know is that this can provide significant relief with a major impact on your quality of life, but don't expect it to make you go from leaking all the time to completely normal. That being said, I've had some patients that have had that happen, but it's not something that we can guarantee. The stimulation, most patients have no concern with the stimulation. It sort of feels like a little fluttering sensation, sort of in the bicycle seat area. Your brain tends to turn it off pretty quickly. So you may feel it. And then I've had a few patients say, doc, I'm not feeling it. Maybe the system's not working. It's just your brain tunes it out so that you don't have to be feeling that all the time. It is covered by all insurances, Medicare. And so that's usually not an issue with cost. We always make sure that we work with the insurance companies to get it all approved because no one wants any surprise bills. The last and most important question is that, can I have an MRI? Because traditionally, a lot of people shied away from this technology because they needed MRIs for back reasons and other reasons. But this system is fully MRI compatible now. So all systems that we do basically allow you to still have all your MRIs, and you don't have to worry about getting it removed or anything like that before getting an MRI. I just want to thank everyone, for tuning in and hopefully you learned something today. And please let me know if I can be of any help to you, and look forward to speaking with you further.
Again, this is David. I just wanted to say that if you do have a question, that there's a Q&A box at the lower portion of your screen, and you can just type in a question there. We'll give everybody, about a minute to type in a question and we can answer those. Dr. Patel, the first question is where are you located?
So I'm located primarily in Sandy Springs, so just inside the perimeter, as well as Lawrenceville, Georgia, and Brazelton, Georgia. So I have a pretty large spread in geographic area that I see patients in. Those are my locations. Obviously, our practice as a whole is all over Metro Atlanta. We have great doctors throughout our practice that may be closer to you and where you live that we can put you in touch with. But those are the locations that I'm in.
Okay, and then the next question is, does drinking a lot of water does it cause an overactive bladder?
So I think it's really important, the normal amount of water intake you should be taking in a day is about 2 to 3 liters of water. And so if you're taking in a normal amount and going to the bathroom quite a bit, it doesn't mean that you're drinking too much water. It probably means that you have an overactive bladder. And so it's really important that, I recommend to all my patients, don't dehydrate yourselves just to give you better urinary habits. I understand why it's a natural way to do it, but dehydration and not drinking enough water can lead to other chronic health issues related to your kidney, your brain, your heart. And so it's really important that, if you're drinking 4 or 5 liters a day, that's a different story. But if you're drinking about 2 to 3 liters a day and you're having a lot of overactive symptoms, it could be because your bladder is just overactive. And there are things that we can do, again, to help it accommodate, drinking a normal amount of fluid so that you're not going to the bathroom so often.
Okay, and then the next question is, the medication I was given for OAB so that I would stop going 4 or 5 times a night. I am sleeping all night now, but the medication was preventing me from going during the day. Can medication for OAB do too good of a job? And are you able to shower normally if you have the implant put in?
Yeah, so sometimes the medicine can work really well. We have a lot of patients that are like, it really helps me at nighttime, but I feel like I'm having a slower stream during the day and I'm not emptying well during the day. We could always work on some dose adjustments to figure out a better way, medication wise. But again, I think, especially if it's not a prostate issue and your prostate is treated and you're urinating well. Obviously, if you're a female, it's a little bit different a story. And sometimes females are a bit more sensitive to some of these medications. I had a patient earlier today that I saw that was doing really well, but she said, look, now I feel like I'm just not emptying as well as I used to, but I'm sleeping through the night and otherwise everything is fantastic. So we can adjust the dose of the medicine, but more importantly, if you think you're a good candidate, or we think you're a good candidate for advanced therapies, then this type of procedure would be great for you. And yes, you can shower. The incision, you won't even know where it is within like a couple weeks. Most people go back to their lives within a day or 2 of the procedure. Like I said, it's a very minor outpatient procedure that we do. I don't even really consider it surgery. It's something that can be done even with local anesthesia, although most people would like to have a little bit of a nice nap when we do it. But it's a very minor outpatient thing, and it heals well, and no one knows that you have it. And most of my patients have to even search for it sometimes to find it themselves. So it really is a non-intrusive thing in your life. It's just like, many people have pacemakers for their heart, and it's right underneath the skin and doesn't bother them at all. It's the same thing.
Okay, I'm just going to go through them here. What if I've already tried Botox? Would INTERSTIM work for me?
Yes, absolutely. I'm a big fan of, I have a lot of patients who have come and seen me who've had Botox, maybe because their other urologist or clinician were more comfortable doing that. It works in a different way. And so absolutely, I do think that even if you've had Botox before, you may find a significant improvement here with the trial. And I've had a lot of success with it. I mean, not every, like I said, it's 70 to 80% success rate. It just depends on sort of where you are and what you've tried and what you've done. And I definitely think that if you haven't had a trial, you should definitely have a trial. And if you've had a trial by someone else, or if you've had a trial where you felt like, hey, just something didn't go exactly right, and I didn't feel it how I was supposed to feel it, it's always worth doing it again. I've had many patients who've had a second trial after not as good of a first trial, and they were so happy that they did because they realized that it was a good option for them.
Okay. How exactly does the INTERSTIM work? Yeah, that's the question. How exactly does the INTERSTIM work?
So basically, your bladder receives a calming signal from your brain at all times during the day, so that you can go about your activities and not worry about it. When your bladder gets really full, it will send out signals, right? As it starts feeling, normally you'll feel like, oh, I feel like I have to go. But then as it gets fuller and fuller and fuller, it's still able to filter out all of that sort of pressure until it's really time to go. And then it's like, okay, now I got to go to the bathroom. And so what the INTERSTIM device does is it reintroduces that calming, filtering signal to your bladder so that it is not constantly trying to contract and go when it's not supposed to. Because if the bladder is trying to contract, then your nerves sort of at your bladder opening feel, and it tells your brain like, hey, I got to go. I really got to go. This bladder is not waiting for anything. And so what this device does is it sort of reintroduces the normal signaling, calming signaling to your bladder so that it stays calm when it's supposed to, but then when it's time to go, that will make it to your brain so that you know to go. So it sort of reestablishes that sort of calming sensation to the bladder that it had for hopefully for some point in your life before all this started getting worse. And so it basically sends a nice sort of gentle stimulating signal into the area of the nerve that is going to the bladder and the bowel. And so that's how it sort of keeps that nerve stimulated, but stimulated to calm, which is really important to
know. Is emptying the bladder 6 to 8 times a day normal? And does having to empty the bladder 10 to 12 times a day qualify for the Medtronic? For the INTERSTIM?
Technically, you qualify, someone who has frequency, which could qualify you for the device. Again, it's really important that you try first-line therapies like diet, lifestyle, pelvic floor physical therapy, and medications as well, just to make sure, to at least try those to see how well they work for you. But yeah, so if you did have that, you would qualify for it. I think it's really important as well to know that, how much does 8 to 10 times a day bother you? I have tons of patients that say that's a lot, and I have some patients that are perfectly happy at 8 to 10 times a day. And so if it also depends on your quality of life and how much it's affecting you. And I think that's really important because what we're trying to do here is improve quality of life.
Okay, there's a few questions here that are all kind of the same, so I'm just going to kind of sum it up here. Basically, if an INTERSTIM is not working, what can you do? And then how can a second trial work better than the first? Do you insert this INTERSTIM in a more direct spot close to the bladder nerve?
So the first thing is for the INTERSTIM device, there are about 200 different ways you can program it. And so we will continue to, so if you don't have exactly what you want immediately, which we usually aim for, we do a lot of different programming. So 2 weeks after your procedure, you come in, you'll see one of my assistants who will program and check everything out. And if you say, hey, I'm doing great, fantastic, we won't see you again for 6 months. If you're saying, hey, look, I'm a little better, but I'm not where I want to be, then we'll make some programming adjustments until we get you to where you want to be. And so we usually try and reprogram, every 2 weeks until we get to the right setting, because it does take time for it to work. As far as the second trial is concerned, a lot of things can happen there. The trial wires that we use are very flimsy. They're not designed to be any sort of permanent things that hold themselves in place. So a lot of times people will go home and they'll bend over, or they may do something that they don't realize, and the wire could get loose. And loose meaning that it's sort of moved from where it was originally positioned properly during the insertion. And then that may cause you to not have as good of a response to the trial. And so we do try and say, hey, look, make sure you don't go bend over, make sure you don't, sit down in the bathtub, make sure you don't do yoga, make sure you don't do all these different things that could make that happen. Because again, the trial is not designed to be anything permanent. It's supposed to be something temporary to make sure that we're on the right pathway to success.
Okay. And we got a bunch of questions on this. So I'm just gonna basically, what is the recovery like after I get an implant, or what's the downtime after the surgery?
The downtime is like a day or two. I've had many patients who go back to work within 1 to 2 days. I usually do them on Thursdays. So most of my patients take Friday off, and then they're back to normal, even on the weekend. The pain wise, it's very minimal. I would say most of my patients take Tylenol and Advil, but we do give you something stronger just in case. Really, there's no, like I said, most people go back pretty quickly, and they see that improvement fairly quickly too, which is nice to have both. So the recovery time is very quick. Like I said, it's a minor outpatient procedure. Imagine like you're getting a tattoo. That's sort of the level of sort of discomfort or pain you may feel.
Can you go through airport screening with it?
Yeah, absolutely. So you do get an implant card from the company that you can let them know that you have it, so that if something does go off, they can just scan you and let you know. But generally, everyone does fine. I haven't had any patients complain about airport travel.
Okay, and there was a few on locations. There's one specifically, just asked, I live in Athens, Georgia. I would like to try this. And then the rest are just like, what are some locations that you're at?
Oh, so the closest, for Athens would either be our Lawrenceville office or our Brazelton office. Those are the two closest locations to Athens for me. What we would do is to do the trial, generally, if I haven't seen you, I would obviously like to evaluate you, see what you've tried, and understand where you're at and sort of the pathway. And if you are a good candidate for it, then we could definitely do a trial in our Lawrenceville location. And if it's successful, then we could do an implant. But that would probably be the closest location to you.
Okay. All right. That is all. There's one about, is this done at your office or surgery center, which I think you just answered, but
yeah. So
yes.
So it can. So the trial can be done in the office or the surgery center. But generally, we always do in the surgery center because we have access to an X-ray machine. So it just makes us more accurate than if we do it in the office. So when we have the X-ray machine in our surgery center, there's less pokes in the back to get the wire in. It really just makes it much more seamless and a better overall outcome for our patients to do it with X-ray guidance. So I always recommend that we do it in a surgery center. It also gives you the ability to not have to be awake if you don't want to, and it just more comfortable for the patient and a better experience overall, and gives you the best possible outcome.
Okay. And the last question, and we get this a lot, or questions that have to do with this, and the subject is, what is your sex life like?
So not there's really, life,
yeah.
So I have a lot of men and women who've had this. It doesn't really change it at all. They have no sort of, it doesn't affect them in any sort of way, negatively or positively. There is a vibration sense that some women will feel sort of in the bicycle seat area, but it is very minimal. And again, like I said, your brain filters it out. So it's really not that big of an issue. I've never had anyone complain about it.
All righty. Well, I just want to thank you, Dr. Patel, for hosting this event with us tonight. It was extremely informative, and we're all grateful for your time. And thank you, everybody, for joining us. Please jot down the phone number for Dr. Patel's office so you can schedule an appointment. Much of what was discussed tonight is relevant to many of you, but each and every person is unique, so it's always beneficial to make an appointment. And if you don't mind, please fill out the short anonymous survey once the event concludes. It'll appear on your screen, and it'll also be emailed to you. Thank you very much. Everyone have a good night.
Thank you, everybody.